Visual pathway. So Nolte chapter 17, and this is a pretty cool looking picture if you ask me of a functional MRI, and we can see the optic chiasm here. Okay, so see these are the eyes, okay, and this is the back here, so that occipital lobe back here where things are kind of ending up from the visual pathway here. So let's look onto the next page here. So we're starting off on page 441 of Nolte's The Visual Pathway. Okay, so some of the earlier stuff in the book is going to give you a lot of the anatomy and physiology of what we've already covered for the eyes. So we're going to look right here. I'm going to read this page to you, and then we're going to kind of unpack the information here with the following slides with a lot of visuals or pictures explaining it. So let's just read this. Half of the visual field of each eye is mapped systematically in the contralateral cerebral hemisphere. So contralateral, opposite side. Ganglion cell axons travel in the optic nerve to the optic chiasm, or that crossover, okay, where they undergo a partial decussation or crossing over and enter one of the two optic tracts. Most of the fibers in each optic tract then terminate in the lateral geniculate nucleus. Sometimes you'll see it called lateral geniculate body, and this is of the thalamus. The thalamic relay nucleus for vision. Geniculate fibers travel through the internal capsule and corona radiata to the primary visual cortex and the banks of the calcarine sulcus. In addition, a considerable number of optic tract fibers project directly to the midbrain and a few to the hypothalamus. Throughout the pathway from the retina to the cerebral cortex and to the superior colliculus of the midbrain. The numbers of fibers and areas for representation for the macula are disproportionately large for the macula's actual size. This reflects the relatively small amount of convergence in the macula, which in turn reflects its specialization for high acuity. Now this paragraph has a lot going on here, so we're going to unpack this in the next couple of, in the next hour or so. I want to point out a couple of things here. So lateral geniculate nucleus / body is of the thalamus. Okay, the relay center here. Primary visual cortex, it's going to be Brodmann area 17. Okay, the calcarine sulcus we'll see later. Superior colliculus, you remember this being the visual reflex or the startle response, right? You see something out of the corner of your eye and you turn and you look, as opposed to its buddy, the inferior colliculus, which is you hear something out of the ordinary and you turn and you look. Both end with turning and looking. So here's a nice visual of the paragraph from the last slide. So we're looking here at the optic tract on the left and then the thalamic nuclei on the right for reference to that lateral geniculate body. So if you look to the left first, we see the eyeball and we see the retina at the back. And then we see the optic nerve coming from the eyeball. And then it crosses over at that optic chiasm or chiasma. It doesn't matter which way you want to say it, it's fine. That's where that crosses over. After the optic chiasm is when we call it the optic tract. And then you can see where the little circle is posterior to the optic tract there. That's the lateral geniculate nucleus or lateral geniculate body. You could call it either one. Of the thalamus. And if you look over to the right, I'll grab my red marker and circle lateral geniculate body here. And it's this little bump off the pulvinar at the back here, the posterior aspect of the thalamus. So coming back over here, you could see these areas here aren't labeled yet, but that's called Meyer's loop, and you'll see that later. So you don't have to totally remember that yet, but you'll see it later on in the PowerPoint. And then we call these the optic radiations. And it terminates here in the visual cortex, or Brodmann's area 17, we'll also call it. And then this is really just the occipital lobe. And here's a lateral view of the visual pathway. Starting on the left, you can see the eyeball and the optic nerve, and then the optic chiasm is kind of hard to see here, but you can see the words of it on the bottom of the screen there. And remember, after the optic chiasm, we call it an optic tract. You can see it synapsing there at that lateral geniculate body of the thalamus. You can see the Meyer's loops here of those optic radiations coming down and around into the striate area. And we'll talk about the striate area a little bit onto slides 8 and 9. Up top, you can see the lateral ventricle area is kind of like that shaded area. And the next picture is a blank picture of this exact slide. So pause and go back and forth and make sure that you can label these slides, this picture, because this one notoriously shows up on your final exam, and I think it's a good one illustrating just how much real estate the visual pathway takes up. So again, feel free to pause here and work out this picture, making sure that you know what these different structures are. Like the retina, this part of the visual pathway belongs entirely to the central nervous system, namely to the diencephalon, and it's surrounded by meninges. Thus, the optic nerve is an extension of the diencephalon, not a regular cranial nerve. So cranial nerves 1 and 2 are of origin, embryological origin, just the same as the brain, not necessarily the like the rest of the cranial nerves 3 through 12. So optic nerves join below the base of the diencephalon to form the optic chiasm, which then divides into the 2 optic tracts. Each of these tracts divides in turn into lateral and medial root. So the lateral geniculate body of the thalamus, and there's our reminder picture from chapter 16. So looking at that lateral geniculate body off the pulvinar in the back on that green structure in the back there. So 90% of the optic nerve fibers terminate in this lateral geniculate body on neurons that project to the striates area. This is the genicular part of the visual pathway. It is concerned with conscious visual perception and is conveyed by the lateral root of that optic tract. The remaining 10% of the third order axons in the visual pathway do not terminate in the lateral geniculate body. The optic radiation begins in the lateral geniculate body of the thalamus, forms a band that winds around the inferior and posterior horns of the lateral ventricles, and then terminates on that visual cortex or the striate area, or what we're going to call Brodmann's area 17 after we get into all of the different Brodmann's numbers. It's located in the occipital lobe. The visual cortex can be grossly identified by a prominent stripe of white matter in the otherwise gray cerebral cortex, and that's that striate area, or what you might see it called the stria of Gennari, but we're getting away from calling things by proper names, so just the striate area. You can see the picture there as well. So located in the occipital lobe, the visual cortex can be grossly identified by this prominent stripe of white matter in the otherwise gray cerebral cortex. So this white stripe runs parallel to the brain surface and is shown in this inset where the gray matter of the visual field is shaded light red. Another couple pictures here so you can kind of identify that. So here on the left they're calling it the line of Gennari. You can see it in blue lettering there. On the right, I snagged a couple pictures here to show you. On the upper right, most of the cerebral cortex having 6 layers. Input into the visual cortex terminates in layer 4, which is extra thick in the visual cortex. So 4, the way I remember this is foresight, right? So like you have the foresight to like know something ahead of time. Foresight, S-I-G-H-T. That's how my brain remembers it. If that helps you, cool. If not, that's okay too. In the myelin-stained brain sections here, layer 4B has many myelinated axons and forms a stripe. That's the stria of Gennari. So visual cortex is also often known as the striate cortex. Anytime that you see something with a lot of white matter, know that this is an area that can be troubled in multiple sclerosis, and the visual pathway is notorious for being some of the first signs and symptoms of multiple sclerosis. So if they have some sort of visual field deficits that are a little odd, that's one of the things that you want to think of in your differential diagnosis. This is another nice picture. This one's in your book of adding in the visual field to what we already looked at. So we could see the visual field up top. Please note that when we're looking here, the purple is on the right side of the visual field and the green is on the left side of the visual field. Now look at the eyeball. The purple is on that crossed over side. Okay? And then follow the coloring all the way down, so that purple is going to be on the left and then that green is going to be on the right. So what aspect of the brain is responsible for what part of the visual field? And if we have visual field deficits that are a little odd, we're going to go ahead and kind of play this game of locate the lesion, and we'll look at that in a couple more slides. So the only way to make this make more sense is to just draw it out. So draw 2 circles at the top for the visual field. Draw 2 circles for the eyes. And then I draw the optic chiasm. And then I draw the lateral geniculate body. And then I connect the dots. So then crossing over that visual field to the eyeballs. And then eyeball to same side all the way back through the optic chiasm to the lateral geniculate body, all the way back to the occipital lobe, and then another line crossing over at that optic chiasm, and then going over to the lateral geniculate body, and then to the occipital lobe. And then the same thing on the other eye. So just kind of trace this out if that was hard to follow. So just draw it out a couple of times, label it a couple of times. In 2 slides from this one, I have a blank one for you to label as well. Nolte page 443 describes fibers from the nasal half of each retina cross in the optic chiasm. So we're going to see a picture of this in the next slide, and it will at first seem kind of complex. So let's talk about it a little bit first. So the unmyelinated axons of ganglion cells collect at the optic disc, pierce the sclera in a region called the lamina fibrosa, acquire myelin sheaths, and form the optic nerve. Embryologically and in its adult anatomy, the optic nerve is actually a tract of the central nervous system, and as such has meningeal coverings much like other areas. The sclera continues as its dural sheath, so the dura, so remember pia, arachnoid, and dura, so this dural layer over it, lined in turn by that arachnoid and pia. The subarachnoid space around the optic nerve dead ends at the back of the eye, but communicates with the subarachnoid spaces around other parts of the brain. Increases in intracranial pressure are therefore transmitted to the optic nerve, compress it, and choke off both venous flow and axoplasmic transport. The resulting edema or swelling or inflammation and engorgement of axons cause a characteristic swelling of the optic disc called papilledema, which can be a valuable diagnostic sign of intracranial pressure, or ICP, often due to hydrocephalus, or what you see there, hydro being water, cephalus being head. Okay? So like our grandparents would have called that, like a hydrocephalus babies would be waterhead babies. So we're going to look in the next slide here of the pictures and try and bring this to life here. Here is your blank slide promised a couple slides ago in order for you to practice understanding where this anatomy is. So this one tends to show up on exams as well. So take your time, pause this. I had to write this out on the whiteboard a bunch of times. I think whiteboards are extremely helpful. If you're still at home, it might be hard to get a whiteboard. But I got whiteboard paper. It's like contact paper for your walls, and if you're in a rented apartment, it totally works with that as well. I think I got it for like 12 bucks off of Amazon, and it comes with a couple of dry erase markers. If that helps you, great. If not, it's not required. But it's really the repetition of drawing it out and writing it out is really one of the best ways to get this information. Visual field deficits can get pretty tricky. So we're going to look at this from a couple of different resources. I put in the Nolte page in the next slide. We're going to go through this, and then you're going to see this in your function class as well. So the more times you see it, the more familiar it's going to get. And we have a whole nother chapter or two left to explore that'll help you understand this as well. So if you don't get it and you feel frustrated, it's okay. That's just the stage that we're in right now. So it's a confusing topic for some people. If you get it, great. Skip on ahead real quick. But if you're having trouble, know that you are not alone, and that's the normal stage of trying to learn this subject. So visual field defects or deficits, either one's fine. Visual field defects and lesion sites are illustrated on the next couple of slides here. I think it's actually 2 slides ahead for the left visual pathway. Lesions of the visual pathway may result from a large number of neurological diseases. The patient perceives the lesion as a visual disturbance. Because the nature of the visual field defect often points to the location of the lesion, it's clinically important to know the patterns of defects that may be encountered. Division of visual field into 4 quadrants is helpful in determining the location of a lesion. The quadrants are designed as upper and lower temporal, and then upper and lower nasal. Now this temporal, okay, so off to the sides of your head, and then nasal towards your nose. And then it's going to be in quadrants. So think of just like a little bullseye for a focus circle. So we'll see that in the next couple of pictures. So this is what Nolte on page 446 has to say about it. So deficits resulting from damage to various parts of the visual pathway are named according to certain conventions. Most importantly, visual defects are always named according to the visual field loss and not according to the area of the retina that is not functional, so visual field loss. Because the retinal image is inverted and reversed, so it is upside down and what's right is left, so it's upside down and backwards, of course, right? Damage to the temporal areas of the retina cause nasal field losses, and damage to superior areas of the retina cause inferior field losses. The combining form anopia is used to denote loss of one or more quadrants. So look at that word, op in the middle of it. So that's telling us it has to do with vision or optic. And then an or a in front of a word tells us without. So hemianopia, remember hemi means half. So this is half of vision loss. Okay? So refers to loss of half a visual field. Quad, note the quad part in there means 4, so quadrantenopia, loss of 1/4 of the visual field, or what we call pie in the sky. Finally, the term homonymous denotes a condition in which the visual field losses are similar for both eyes. And heteronymous denotes a condition in which the 2 eyes have non-overlapping field losses. So homonymous losses may be congruous or essentially identical or overlapping but non-congruous. Okay, what does that mean? We have pictures. Okay, so I'm gonna take you through this, and we're gonna go over this over and over and over again until you guys get it, and we've got a couple more chapters, so it'll be all right. So this is the slide. Don't let it scare you. Don't let it intimidate you. You've already drawn out the visual field in some previous slides, so go ahead and grab that or do that. You can pause that and draw out the visual field. And the way to look at this is see the circles on the right and left of that visual field picture and the visual system picture there. You could see that that's the left visual field and the right visual field are those circles. Okay? So note the number 1 through number 7. It's the dark areas are telling you where the blindness is. So number 1, you could see left total blindness off to the left there. You could see the explanation. And then number 2 is bitemporal hemianopia. So hemianopia being half blind, right? Bitemporal on both sides, or two, right? On both sides of the temporal area. Right? So that's what's shaded dark there, so they can't see. It's kind of like having blinders on, but they don't necessarily actually know this is the issue on some of these, because the brain confabulates or makes up that it can see the whole visual field for some people. Especially some of the littler ones, like number 7. How would they even know they're not seeing that? They're moving their head around subconsciously in order to figure out where that vision is coming from. So number 3, homonymous hemianopia. Kind of sounds like a Harry Potter spell, but it's not. So number 3, you can see how it's both on the right side. So we see that number 3 is towards the nasal aspect on the left there, and then number 3 is towards the temporal aspect. So that's why we call that the homonymous hemianopia. So it's both on the right side, loss of vision there, but that's where we get those words from. Number 4, contralateral, so opposite side, okay? Contralateral upper quadrantopia. So that's that pie in the sky deficit. You can see what that means now. So you can see it looks kind of like a piece of pie. Number 5, contralateral lower quadrantopia, just different pie in the sky. And then number 6, homonymous hemianopia, macula sparing. So the macula is in the center, remember. So macula fovea area is being spared. Number 7, homonymous hemianoptic central scotoma. So scotoma, you'll see scintillating scotoma used when describing a migraine. That's those kind of sparkly lights, as your patients will describe it, or that kind of when I used to get migraines, my scintillating scotoma, the way I would describe it was it looked like there was a ceiling fan going off in the corner of the room, and then I would look and there'd be no ceiling fan. So any of those weird kind of visual field effects, that's that scintillating scotoma is where you're going to see that in like migraines. So note, all homonymous visual field defects are caused by a retrochiasmal lesion. What does that mean? If it's back behind or after the optic chiasm, or where it crosses over, if you look to the picture where number 2 is, that's the optic chiasm. If it's back behind there, that's where you're going to use the word homonymous, okay, if it applies. Okay, so we can see homonymous and we can see contralateral. So you're not going to use the word homonymous for hemianopsia unless we are back behind that optic chiasm. Okay, so if you look at the picture now, we can see that left optic nerve in number 1, and they're not going to be able to see anything out of that left eye if the left optic nerve is completely severed or damaged. Okay? If the optic chiasm is damaged in number 2, just the areas that cross over are going to be damaged. So ipsilateral information coming from the eye, optic nerve, and then if it's not crossing over, it's going to stay ipsilateral and go into that optic tract area, and then synapse there at that lateral geniculate body, and then Meyer's loop and optic radiations and back to Brodmann 17. That's still intact. So we're going to see that number 2 be that bitemporal hemianopsia, because you can say anopia or anopsia, either one's fine. So you're going to see that because the crossover isn't getting the message. And then number 3, okay, so see the color coding of the purple and the green. So that purple area is going to be of deficit, is how you do these things. And then number 4, that's up in the Meyer's loop, and you can see where it's cutting off just a little bit there. That's why we're getting that pie in the sky. Number 5, a different pie in the sky look to it. Number 6 is where we're going to see in the next couple of slides here an explanation of that, on why that gets kind of tricky there. So that has to do with the calcarine sulcus and that little bullseye understanding. So we'll move into that in a minute here. So note, this is the slide with the calcarine sulcus or calcarine fissure. Remember, sulcus, fissure, sometimes interchangeable. Fissure usually means that it's a little bit deeper of a crack. You'll see it as both. So I just circled that for you so you could see this area in here is that crack. Now look at the numbers here, and then let's go up top here.
So we can see the left upper visual field, left lower visual field, right upper, right lower. And this is what I was talking about, like that little bullseye of like a focus on a camera, right? So separating right from left and up from down. So now looking at the area up top where 1, 5, and 9 in that upper left visual field. Now look down here where it correlates. So we could see 1 over here, right? 1 over here. And then we could see 5. And we could see 9, right? And then we could see on the right area here, so 3, 7, 11 up top here, 3, 7, 11 here. So what was up is down, and what was on the right side is now on the left side, is what that means. Am I going to quiz you on this? No. Right? So on the specifics, no, I'm not going to make you fill in the blanks or anything like that, but just the idea that what was up is now down, and what was on the right is on the left. So this is the way that our vision works, which is extremely complex. And always just a little amazing to me on how did they figure that out? And how do we figure anything out in neuro? We see a deficit and we kind of walk back from there in order to figure out the normal anatomy usually. The next couple of slides here are the book's definition of what you just saw, those pictures. So go ahead and pull up that picture if you like, and I will read these out to you. It's basically the explanation that I just gave you on that slide, but I wanted you to have the book's definitions as well. So number 1 on that picture, so the one at the top, a unilateral optic nerve lesion produces blindness in the affected eye only. Number 2, a lesion of the optic chiasm causes bitemporal hemianopia, as in a horse wearing blinders, because it interrupts the fibers from the nasal portions of the retina, the only ones that cross in the optic chiasm, which represents the temporal visual fields. Number 3, a unilateral lesion of the optic tract causes contralateral homonymous hemianopia because it interrupts fibers from the temporal portions of the retina on the ipsilateral or same side and the nasal portions of the opposite or contralateral side. Thus, the right or left half of the visual field is affected in each eye. Note, all homonymous visual field deficits or defects are caused by a retrochiasmal lesion. Remember, that's back behind post optic chiasm, or where it crosses over. Number 4, a unilateral lesion of the optic radiation in the anterior temporal lobe, or Meyer's loops, leads to a contralateral upper quadrantenopia, okay, the pie in the sky. This occurs because the affected fibers wind around the inferior horn of the lateral ventricle in the temporal lobe and are separated from the fibers that come from the lower half of the visual field. Number 5, a unilateral lesion in the medial part of the optic radiation in the parietal lobe leads to contralateral lower quadrantenopia. This occurs because the fibers course superior to those for the upper quadrant in the Meyer's loop. 6, a lesion of the occipital lobe leads to homonymous hemianopia because the optic radiation fans out widely before entering the visual cortex. Lesions of the occipital lobe have been described that spare foveal vision, okay, so fovea of the macula. These lesions are most commonly due to intracerebral hemorrhage, so a bleeder. The visual field defects may vary considerably because of the variable size of the hemorrhage or the bleed. A lesion confined to the cortical areas of the occipital pole, which represent the macula. So remember, macula and fovea go together. So fovea is just the pit in the macula of sharpest vision, is characterized by homonymous hemianopic central scotoma. So I put there the definition of a scotoma for you. So a spot in the visual field in which vision is absent or deficient.
So a quick little reminder here, because you'll get this in Dr. Rabatsky's class, but the macula is small, measuring about 5 millimeters in diameter, and then the central area is the fovea. So looking at the picture there, it is the little box with the red writing macula there, and then the fovea is the pit in the center of that, and that's going to be where the sharpest vision is. And you might have heard of like macular degeneration, and you'll probably be studying that in your function class as well. So it happens, it's the most common cause of blindness in young and middle-aged people. So age-related macular degeneration, most common cause of blindness in the elderly. So the non-geniculate part of the visual pathway, so the part that does not go to the lateral geniculate nucleus of the thalamus, is approximately 10% of the axons of the optic nerve do not terminate on the neurons in this lateral geniculate body for projection to the visual cortex. They continue along the medial route of the optic tract, forming the non-geniculate part of the visual pathway. The information from these fibers is not processed at a conscious level, but plays an important role in the unconscious regulation of various vision-related processes and in visually mediated reflexes. So think about the afferent or the sensory limb of the pupillary light reflex. Axons from the non-geniculate part of the visual pathway terminate in the following regions. So axons to the superior colliculus. The next slide is your reminder slide for the superior colliculus. So we'll look at that in a second, but that's that visual reflex, remember. Transmit kinetic information that is necessary for tracking moving objects by unconscious eye and head movements, or what we call the retinotectal system. So retina and tectum. Remember, superior and inferior colliculus are part of the tectum. Axons to the pretectal area, or afferent sensory, for pupillary responses and accommodation reflexes, being the retinopretectal system. And so let's take a look at our superior colliculus. Who could forget superior colliculus? And the little girl here surprised by the dolphin. So it's that visual reflex. We see something out of the corner of our eye and we turn and we look, and you can see that her accessory nerve has gotten involved in that as well. So the SCM and upper trap, so she's protecting her neck and turning her head all at the same time. We want to remember that as chiropractors when our patients show up with their shoulders in their ears, right, and really tight upper traps. So we want to know that it's part of this pre-programmed stress response. And the corpora quadrigemina is the name for the 4 of these bumps here. So corpora, body, quad, 4. So that's the 2 superior colliculi and the 2 inferior colliculi combined. And you can see the superior colliculus is in green there, and then the 2 bumps underneath those green bumps are the inferior colliculi, which are responsible for auditory reflexes. So figure 20.469b is that tiny little picture on the right, and don't strain your eyes. I have a picture of it on the next slide really big, but I just wanted to let you know which one we're actually talking about here. So the non-geniculate part of the visual pathway. So not that lateral geniculate body or geniculate nucleus of the thalamus, but the 10% that's going to the other area. So axons to the suprachiasmatic nucleus. So look at the word chiasmatic in there. So think optic chiasm, okay, supra above. So suprachiasmatic nucleus of the hypothalamus influence circadian rhythms. Now circadian rhythms, remember, are going to be, how do we keep track of night and day? So axons to the thalamic nuclei, or the optic tract coming in the tegmentum of the mesencephalon, so midbrain area, and to the vestibular nuclei, afferent or sensory fibers for the optokinetic nystagmus. Optokinetic, so op telling us eyes or vision, kinetic being movement, and then nystagment is that jerky physiological eye movement, or that kind of wiggle waggle to the eyes during tracking of fast moving objects. This has been called the accessory visual system. Axons to the pulvinar, which is that posterior area, and on that thalamic nuclei, it's that green area, and that medial geniculate and lateral geniculate kind of hang off of that area. So axons to the pulvinar of the thalamus, visual association cortex for ocular motor function. So neurons are relayed in the superior colliculus, which is the visual reflex center. So axons to the parvocellular nucleus of the reticular formation are going to give us arousal function. And here's the picture from your book. So we've seen this before. The eyeball's in the front, obviously, and they either are, the optic nerves are going to the optic chiasm, and it's either going to go on the same side or opposite side. So it's either ipsilateral or crossing over at the optic chiasm and becoming contralateral. So these things are symmetrical on both sides. It's only labeling the one side here. So we can see the different terminal nuclei there along the pathway in yellow. And then following that red one back, we can see it going all the way up to that suprachiasmatic nucleus. If we follow through here, I'll take my green pen, how about that? So we're coming through here, and then we're going to go here, these blue guys, that's superior colliculus. Okay? So you got to see something out of the corner of your eye in order to turn and look. That's superior colliculus getting involved in that. And then this little purple area, it's in front of the tectum, right? So superior and inferior colliculus is the tectum, so that's the pretectal area in purple. And then you can see the lateral geniculate body right here. That's of the thalamus, and then remember these are those Meyer's loops of the optic radiations coming back through here, hitting the occipital lobe or Brodmann's 17, the visual cortex. You can see that striate area. And this slide is just another blank slide. I don't test you on this, but if you want to kind of test yourself and write in the words, that would be what this is here for you. So let's talk about brainstem reflexes. So the clinical importance of the non-geniculate part of the visual pathway here. So we can test it with some reflexes here. So if you look to the picture to the right, there's some numbers here. We're going to look at pupillary light reflex, the vestibulo-ocular reflex, and the corneal reflex. So brainstem reflexes are important in the examination of comatose patients especially. So loss of all brainstem reflexes is considered evidence of brain death. And 3 of these reflexes are described in the following slides. So note to the picture on the right as well, what we're looking at here is the optic nerve on the left. You can follow that over and see how that gets involved with oculomotor, pupillary, and vestibulo-ocular reflex in the pathways throughout. So on the left, trigeminal nerve, and then the vestibular cochlear nerve as well. So on the left, it's the afferent fibers, and on the right, it's the efferent. E is motor, A is sensory. Number 1, the pupillary light reflex. The pupillary light reflex relies on the non-geniculate parts of the visual pathway. So the sensory or afferent fibers for this reflex come from the optic nerve, so cranial nerve number 2. And then you can see that on the top left area there. So cranial nerve number 2, which is an extension of the diencephalon, remember. The efferents or motor for the pupillary reflex come from the accessory nucleus of ocular motor, or cranial nerve 3, which is located in the brainstem, and you can see that over to the right at the efferent side of that picture. Loss of pupillary reflex may signify a lesion in the diencephalon or mesencephalon. So we do this not in the emergency room looking for signs of life, obviously, but as just a regular part of our cranial nerve exam, and we want to make sure that it is firing on all cylinders, or like nice and quick and responsive and not sluggish at all. So we might pick up on some subtle slowness, sluggishness, some subtle differences. This picture goes along with what I was just talking about. It's really just the visual of what I was explaining, and you could see the damage on the right-hand side there. So when you shine a light into the eye, let's take a look at B here. So let's shine a light into the left eye as they're doing here. And it's on our left. It's actually the patient's right eye. So that's the patient's right eye on our left. So you shine a light into there, the pupil should constrict.
So that right eye should constrict and the left eye should constrict. So if we're not seeing it, neither one of those pupils are constricting. So we know that that's the optic nerve most likely damaged there. And then we see on the other side, or the next one up, we could see that they're shining the light into the patient's left eye. It's on our right, patient's left eye. And that pupil is constricting, and that's making the right pupil constrict. So we know that cranial nerve 3 is working in the right eye. And then we go back up to just darkness up at the top. So that is telling us that the muscle, the efferent aspect, is working for the right eye, but the afferent is not. Looking at number 3, so we can see C down at the bottom there. Okay, at the bottom, the patient's right eye on our left there, shining the light in there, and the pupil is still big. But the left eye, patient's left eye on our right, that pupil is constricted. So we know the message is getting in and telling the other eye to constrict the pupil, but the right pupil is not constricting. So we know that the afferent sensory is working, but the efferent, the right ocular motor nerve, is not working to the right eye. And that is further proof on the middle line of C, because we're shining the light into the patient's left eye on our right there, and that pupil is constricting, and we're getting the afferent in, obviously, because the pupil is constricting, so it's getting the message that there's light, and so it'd be sending the message to the other side, and the efferent still isn't working, so the motor still isn't working. Number 2 on our list is the VOR, the vestibular ocular reflex. So vestibular nuclei participate in the VOR. Most important function of the vestibular system is to generate eye movements that compensate for head movements in order to keep the fovea, or that sharpest vision, fixed on an object. So the idea of that you can walk around and move around and your eyes still know where you are in space and you don't fall over. So sometimes with our MS patients, they'll look away at something and then just fall over. So if you come to yoga club, we do some of these balance moves where we're playing around with the VOR, and it just gives you a little bit sharper balance, and you can train into this area whether you have a deficit or not. So I think it's a really good idea to do with our patients post adjustment. So get the structure aligned and then give us a little bit of a better functioning nervous system. We have seen this picture before. Hopefully it's starting to make a little bit more sense. So this is illustrating the vestibular ocular reflex, or the VOR. Rapidly adjusts eye movements to head movements so that gaze can remain fixed on an object even though the head is moving. So it keeps the image stable on the retina despite movement. So looking over here at the picture on the left, I'll grab my marker. So looking at our eyes here, we can see cranial nerve 6. That's going to go to lateral rectus, remember? And then cranial nerve 3 over here is all others. So SO4, LR6, all others 3, remember? So cranial nerve 6, that's going to be abducens. So here's our abducens nucleus. And then here's cranial nerve 3, innervating that right medial rectus. Here's the ocular motor nucleus, or cranial nerve 3's nucleus. And then, I'll switch colors, in green here, the medial longitudinal fasciculus. Crosses over, that dotted line is the midline of the brain, crosses over, chats with the abducens nucleus here, and then in with the vestibular nuclei. Here's another little synapse here. And then we can see that vestibular ganglion. And what we're looking at here is the right horizontal canal seen from above. So in your ear. Okay, so figuring out where are we in space. So remember that chapter when we were talking about the canal. So this is going to allow for the eyes to stay yoked and focused on an object clearly while we rotate our head. So try it by
holding your gaze on something. So look up from your computer and look far away. Focus your gaze on something. Keep your eyes on that, and then turn your head like you're shaking your head no while keeping your eyes focused on that object. That is an example of the VOR keeping you steady while you do that. It's kind of a fun fact, interesting way that they test the VOR and can do a little rehab with some patients is they'll irrigate the ear canal with either cold or warm water. So they'll irrigate the ear canal with cold water in a normal individual. That's going to evoke nystagmus, okay, that kind of wiggle waggle to the eyes that beats towards the opposite side. Right? Afferent fibers are conveyed in the vestibular cochlear nerve, and efferent fibers in the ocular motor nerve. So when vestibular ocular reflex is absent in a comatose patient, it's considered a poor sign because this reflex is the most reliable clinical test for brainstem function. It's also a way that they can kind of work to play around with some neuro rehab with your patients. So why are there some cows there, you ask, right? So the mnemonic is cold, opposite, warm, same. So cold, the corrective nystagmus beats towards the opposite side, and then warm would be same side. Number 3 on that list was the corneal reflex. So these are cranial nerves 5 and 7. Okay, so 5 is going to feel it, 7 is going to make it move, make you blink. Okay, so corneal reflex. This reflex is not mediated by the visual pathway. The afferent fibers for the reflex is elicited by the stimulation of the cornea or touching the cornea of their eye with a sterile cotton wisp, and that travels in the trigeminal nerve, or 5, and the efferent fibers, contraction of the orbicularis oculi, orb being that circular, right? So circular muscle around the eye, oculi, in response to the corneal irritation. So facial nerve is going to be the efferent. The relay center for this corneal reflex is located in the pontine region of the brainstem, so that just means pons. So pathways for convergence and accommodation. So when the head moves closer to an object, the visual axis of the eyes must move closer together. We call that convergence. So you bring something in closer, you kind of feel cross-eyed, right? That's the convergence at action there. And simultaneously, the lenses must adjust their focal length. So we call that accommodation. Both processes are necessary for sharp three-dimensional visual impression. So 3 sub-processes can be identified in convergence and accommodation. So looking at the picture on the right there, we're going to see some problems with vision here. So convergence insufficiency, focused too far after the target. Normal convergence, we can see clearly. Convergence excess, focused too close in or before the target. So information about the object near or far relayed to both occipital lobes via those 2 lateral nuclei of the thalamus. In the occipital lobes, the information is integrated. Okay? The decision to converge for near objects or diverge for far objects is made, it's relayed to the vergence centers in the rostral midbrain near cranial nerve 3's nucleus. Cranial nerve 3 is activated bilaterally, which innervates both medial rectus muscles for convergence, or cranial nerve 6 is activated bilaterally, which innervates both lateral rectus muscles for divergence. We could see the picture here. So number 1, eyes converge through adduction by both medial recti muscles to focus on the near object. And then number 2, eyes diverge through the abduction of both lateral rectus muscles. This shifts the focus from the near object to the far object. And a nice little picture there to go along with it. In convergence, the 2 medial rectus muscles move the ocular axis inward to keep the image of approaching object on the fovea centralis, or the sharpest point of vision, remember. In accommodation, the curvature of the lens is increased to keep the image of the object sharply focused on the retina.
The lens is flattened by contraction of the lenticular fibers, which are attached to the ciliary muscle. When the ciliary muscle contracts during accommodation, it relaxes the tension on those lenticular fibers, and the intrinsic pressure of the lens causes it to assume a more rounded shape. 3. The pupil is constricted by the sphincter pupillae to increase visual acuity or sharpness of vision. Convergence and accommodation may be conscious, so we might do it on purpose, fixing the gaze on a near object, or unconscious, fixing the gaze on an approaching automobile. Most of the axons on the third neuron in the visual pathway course in the optic nerve to that lateral geniculate body of the thalamus. There, they are relayed to the fourth neuron, whose axons project to the primary visual cortex, or Brodmann's area 17. Axons from the secondary visual area finally reach the pretectal area, remember tectal being the colliculi, by way of synaptic relays and interneurons. Another relay occurs at that level, and the axons from these neurons terminate in Perlia's nucleus, which is located between the two Edinger-Westphal nuclei. So visceral ocular motor nuclei is what we call it, kind of a little bit more modern because we're trying to get away from people's names, remember? And the two functionally distinct groups of neurons are located in Perlia's nucleus. For accommodation, one group of neurons relays impulses to the somatomotor oculomotor nucleus, whose axons pass directly to the medial rectus muscle. So that's cranial nerve 3 controlled medial rectus. The other group relays the neurons responsible for accommodation and pupillary constriction to the viscera motor. So visceral, remember, means internal organs. So this is going to be the parasympathetics. So remember, parasympathetics is going to constrict the pupil, and then sympathetics are going to dilate because that dilation is going to let more light in so you can see further out onto the horizon if there's a threat. Right? And parasympathetics is going to be the opposite, so it's going to constrict, so it's going to be rest and digest, so you can read something up close and kind of chill out. So the accessory nuclei of the ocular motor nerve, or parasympathetic innervation, is illustrated here in the following slide here for one side. So here you can see our pupillary sphincter up here, the short ciliary, the ciliary ganglion, the parasympathetic portion of that ocular motor nerve right there is what we're talking about. You can see the pretectal area here. Here's medial geniculate, that's for hearing. Lateral geniculate's part of this visual pathway here. And there is our visceral ocular motor, or our Edinger-Westphal area right there. So let's talk about that a little bit more. So after synapsing in this nuclear region, the preganglionic parasympathetic axons pass to that ciliary ganglion that we just saw, where they synapse with the postganglionic parasympathetic neurons. Again, two groups of neurons are distinguished. One passes to the ciliary muscle for accommodation, and the other to the pupillary sphincter for that pupillary constriction. The pupillary sphincter light response is abolished in tertiary syphilis. So in pathology, they talk about syphilis a lot because it used to be much more prevalent before the advent of antibiotics, and it does a lot of neurological damage. So while accommodation or ciliary muscle and convergence are preserved. So this phenomenon is called Argyll-Robertson pupil. So it's called prostitute's pupil in any of your boards or memorization skills classes because it accommodates but doesn't react to light. So accommodation still works, but reaction does not, and it's caused by syphilis. So take it or leave it for what you will. Suggests that the connections to the ciliary and pupillary sphincter muscles are mediated by different tracts, although the anatomy of these tracts is not fully understood. And there's a little picture there for you. Kind of test your memory. Pupillary light reflex enables the eye to adapt to varying levels of brightness. When a large amount of light enters the eye, like the beam of a flashlight, the pupil constricts to protect the photoreceptors in the retina. When the light fades, the pupil dilates. As the term reflex applies, this adaptation takes place without conscious input from our brains. So that's the non-geniculate part of the visual pathway. Afferent limb of the light reflex. The first three neurons, so the first neurons are going to be the rods and cones. Rods, black and white, cones, color and visual acuity. Second neurons are the bipolar cells. Third neurons are going to be the ganglion cells. So these are in the afferent limb of the light reflex, are located in the retina. The axons from the ganglion cells form the optic nerve. Axons responsible for the light reflex pass to the pretectal area, or that non-geniculate part of the pathway, in the medial root of the optic tract. The other axons pass to the lateral geniculate body after synapsing in the pretectal nucleus. The axons from the fourth neurons pass to the parasympathetic nuclei, or that accessory nuclei of ocular motor nerve, also known as Edinger-Westphal nuclei of the ocular motor nerve. Because both sides are innervated, a consensual light response will occur. So that's how we get both pupils to constrict when a light is shined in the eye. So the efferent of the light reflex, the neurons located in the Edinger-Westphal nucleus, or preganglionic parasympathetic neurons, distribute their axons to the ciliary ganglion. There they are relayed to the postganglionic parasympathetic neurons that send their axons to that pupillary sphincter. And you could see the picture here on the left, giving us a little easier picture of the pupillary light reflex there. And then on the right here, I wanted to show you the lateral view. So if you look up top to the picture there, let me grab my marker and I'll show you. I'll go for blue. So look up here at that visual ocular motor, also known as Edinger-Westphal, right here. Please note where that is in space. So we are here at the cerebral aqueduct between our fourth ventricle here and the third ventricle area up in here. Okay, so superior colliculus is here, inferior colliculus is here, and then just in front is that nucleus of the ocular motor nerve right here. And then it's all going this way. But again, if there's swelling in the brain, this is that thinnest area, and then it'll press into that area for cranial nerve 3, and we'll see cranial nerve 3 muscles that are innervated by cranial nerve 3 issues first, right? So 3, 4, and 6. So eye movements are going to be affected because of that swelling area there. So 3 is really going to take a hit there. You can see 4 would take a hit because of that as well. And then 6 here, it seems to be a little bit more space here, so it wouldn't be as readily irritated by excess fluid in that area. The direct pupillary light response is distinguished from the consensual or the indirect response. So direct is when they shine the light directly into that one eye, it constricts, direct. Indirect, the opposite eye. So if you shine the light into the left eye will constrict, that's direct. If you shine the light into the left eye and right eye, the right eye constricting is the indirect or the consensual response. Loss of the light response due to certain lesions. With a unilateral optic nerve lesion, shining a light into the affected side will induce no direct light response on the affected side. Consensual light response on the opposite side will also be lost because of the impairment of the afferent limb of the light response on the affected side. So if the information isn't getting in, neither one is going to constrict. So illumination of the unaffected side will, of course, elicit pupillary contraction on that side. We call that the direct light response. A consensual light response is also present because the afferent signals, sensory, for this reflex are mediated by the unaffected side, while the efferent signals are not mediated by the optic nerve. Optic nerve is just sensory, remember.
So with a lesion of the parasympathetic ocular motor nucleus or ciliary ganglion, the efferent limb of the reflex is lost, so motor is lost there. In either case, the patient has no direct or indirect pupillary light response on the affected side. A lesion of the optic radiation or visual cortex or the geniculate part of the visual pathway does not abolish this reflex, given that it will affect only the geniculate part of the visual pathway. So here's a lateral view of some of the things that we were talking about, and then just a couple of different of new terms that are going to get introduced and talked about in a little bit. So let's look at the ones that we know here. So looking over to the right, we can see the nucleus of the ocular motor nerve. Again, cerebral aqueduct is right here. So third ventricle to fourth ventricle. This is the cerebellum on this side here. So this is the pons is where we're at. So medulla, pons, midbrain area. Okay. I'm going to erase that so it doesn't look too cluttered. Here we go. So then a little bit further down, you could see the nucleus of the trochlear nerve or cranial nerve number 4. So 3 and 4 just in that area in front of the cerebral aqueduct. And then you can see the medial longitudinal fasciculus. So we saw that connecting, there we go, right here. So 3, 4, and 6 for proper yoked vision. So we saw it connecting 3 and 6 in the previous slides for proper horizontal yoked vision. So right eye and left eye moving in unison at this area here. A little further down in the descending MLF tract, we're going to see further into like the medullary area. We'll see how it's going to connect the lower cranial nerves. But right here, we're looking at the 3 and the 6 and some 4 in here as well. On the left-hand side, these are some of the newer terms. So coming up, let's start up at the top here. So you can still see some rostral interstitial nucleus and medial longitudinal coming up here. So MLF area, the nucleus for that. And then mesencephalic, so midbrain-ish, right? So we're already kind of into the pons area specifically here, but mesencephalic reticular formation. So there's that reticular formation. And then the paramedian pontine reticular formation, or the PPRF. So in the middle, is what this is saying, in the middle of the pons. And look at here, we're deep in the middle of the pons. Great. And that's the reticular formation aspect there. So it's just this whole reticular formation. And where are we? Is all that's saying. And then right here is that nucleus proboscis hypoglossi, and we're going to talk about that in some of the coming slides. So nucleus proboscis hypoglossi. Here's a blank picture to test your knowledge, so make sure that you kind of understand what's going on with that MLF and cranial nerve 3 and 4's nuclei there, and where they are in space and why that's important, because again, it is this right here, that cerebral aqueduct. So any inflammation into that area is going to press onto the nuclei for 3 and 4 and affect eye movements. Here's that conjugate gaze to kind of remind you. We've seen this picture a couple of different times, but these are some complex words and some complex theories of how the brain is working here. So it's a good idea to look at it a couple of times. So number 1, the horizontal gaze center gives input to that abducens nucleus. So abducens cranial nerve 6, remember, so LR6, lateral rectus, to direct gaze to the ipsilateral side. Number 2, one subset of neurons projects directly to ipsilateral lateral rectus, or the same side lateral rectus. So this guy right here. And then number 3, another subset of neurons in the abducens nucleus crosses the midline and travels in the MLF. So that's that dotted line right here is the midline. You can see that it's in between the eyes. And between that abducens nucleus and ocular motor nucleus is the MLF, or that medial longitudinal fasciculus. Remember, this is full of white matter, and this is a common area that gets demyelinated in our multiple sclerosis patients. So checking their eye movements to make sure their right eye and left eye are moving in unison with each other is a good test for our MS patients, and a good neuro rehab exercise for them as well because of this. So number 4, the ocular motor neurons innervate the ipsilateral, same side, medial rectus, cranial nerve 3, and the eye moves to the contralateral side, or the opposite side. Number 5, both eyes move in the same direction, so in this case to the left. So that's the horizontal gaze center, which is located in the PPRF that we just saw in the previous slides, the paramedian pontine reticular formation. So horizontal gaze center happening right there. Conjugate eye movement. So for the left eye, lateral rectus must relax while the left medial rectus must contract. So know that these are that same concept of agonist and antagonist, kind of like how your bicep and your tricep are agonist and antagonistic to each other. So movements of this kind that involve both eyes are called conjugate eye movements. These movements are coordinated by several centers. So the horizontal gaze movements are programmed by that PPRF that we just saw. Vertical gaze movements are programmed in the rostral interstitial nucleus of the medial longitudinal fasciculus. Both gaze centers establish bilateral connections with the nuclei of cranial nerves 3, 4, and 6. The tonic signals for maintaining the new eye position originate from that nucleus purpositus hypoglossae, which was a term I introduced maybe a couple slides ago. Here is that nucleus purpositus located in the caudal pons, upper medulla oblongata, nucleus purpositus, also nucleus purpositus hypoglossae, so note hypoglossus, cranial nerve 12. It's part of that horizontal gaze holding system, and it functions as a neural integrator. This picture, I don't test you on this. This is in the theme book, the THIEME theme book. And if this helps you with understanding that, great. If not, some people say it's a little odd looking. So some people it's helpful, some people not. So take it or leave it on whether you like it or not. I do not test you on it. Here is the blank one for you if you like it to practice on. When we shift our gaze to a new object, we swiftly move the axis of vision of our eyes towards the intended target. So these rapid, precise, ballistic eye movements are called saccades. So we have nystagmus, which is that kind of wiggle waggle, usually associated with some sort of deficit. We have a normal one called optokinetics, but we have our saccades, we have nystagmus, and we have smooth pursuits. Okay, so this ballistic movement being saccades, they are pre-programmed and once initiated cannot be altered until the end of that saccadic movement. So saccades is associated with normal ballistic darting of the eyes. So normally nystagmus is going to be seen as more pathological, but we do have OPKs or optokinetic nystagmus that is normal as well. The nucleus of all the nerves that supply the eye muscles, so nuclei of 3, 4, and 6, are involved in carrying out these movements. They're interconnected for this purpose by that MLF, or that medial longitudinal. Because these complex movements essentially involve all of the extraocular eye muscles and the nerves supplying them, 3, 4, and 6, the activity of the nuclei must be coordinated at a higher or supranuclear level. This means, for example, that when we gaze to the right with the right eye, the right lateral rectus muscle, or cranial nerve 6, abducens nucleus, is activated. It must contract while the right medial rectus muscle, cranial nerve 3, ocular motor nucleus, is inhibited. That must relax. So again, think of agonist-antagonistic relationships. Here's a nice picture. We've seen this before of smooth pursuits, and hopefully it's starting to kind of make a little bit more sense each time that we see it. So starting with our familiar picture here, we can see the left medial rectus here, right lateral rectus over here. So left medial rectus, cranial nerve 3, and its nucleus here. And then over to the right lateral rectus, cranial nerve 6, and its nucleus here. We have the dotted line of the midline of the brain here.
And what's connecting the two? We know that that is the MLF, or medial longitudinal fasciculus. And then we see them join up, and we could see its synapse here at the vestibular nuclei. And it's going to feed into the cerebellum, and then pontine nuclei, and it's going to go up to the frontal eye fields and to the visual association cortex, and this is going to allow us to track a slow-moving object. And the aim is to keep that object on the fovea, or the sharpest point of vision, for both eyes. Nystagmus is that rapid rhythmic back and forth eye movement. So when we do our H pattern, where we have our patient follow our finger in that H pattern, we're looking for nystagmus. We're looking to see if both eyes are yoked together as well. So this nystagmus, this kind of wiggle waggle, real quick back and forth, consists of a rapid component, the quick flick of the eyes in one direction, and a slow component, that slow drift. So remember that it's named for the rapid component. So rotation of the head activates that vestibular apparatus and activates the VOR, or that vestibular ocular reflex, or where you were, we practiced this a few slides back, where I had you looking at an object a little bit further away from your computer. Focus on that object and turn your head like you're shaking your head no, while continuing to focus your eyes on that object. That was for the VOR. So when head rotation is greater than what can be compensated by VOR, the eyes reset with a rapid movement in the same direction as rotation. And then compensatory movement of the VOR can happen. This rapid reset followed by slow movement mediated by the VOR, this is vestibular nystagmus. Interneuronal connections of the VOR. So many secondary vestibular fibers project directly through that MLF and through the adjacent reticular formation to the motor neurons of the ocular motor nuclei, so 3, trochlear, 4, abducens, 6. Gaze stays fixed even though the head is moving. This is a nice picture. I think it kind of integrates the nuclei that we were just looking at. So on the top right, ocular motor, trochlear, you can see that cerebral aqueduct, the MLF, nucleus of abducens. And then if you look to the left, there's that big corticospinal tract. So looking back at our tracks coming from the cortex to the spine, this is that major motor tract. So we can see those corticonuclear fibers and how that all kind of interconnects there. And the blank one here for you to practice your anatomy. And this is just that mid-sagittal section viewed from the left side. MLF runs anteriorly to the cerebral aqueduct on both sides and continues from the mesencephalon to the cervical spinal cord. It transmits fibers to the coordination of conjugate eye movements. A lesion in the MLF results in INO, or internuclear ophthalmoplegia. So whenever I see anything that's running to that cervical spinal cord there, right? So that middle sentence, as a chiropractor, I kind of perk up and start to go, hey, what would a good cervical adjustment, upper cervical, mid-cervical adjustment do to the system here? How are we going to be affecting this system? So why would that have anything to do with their eyes and the coordination of eye movements and their brain balance centers? You saw how the vestibular nuclei gets involved in that as well. And it's not coincidence, it is basic neurology here. So here's a little more on that INO, internuclear ophthalmoplegia, also known as INO. So it's a lesion of the medial longitudinal fasciculus. So full of white matter, remember. So if I see a lesion at the MLF on any test question or any slide or any patient or any report on an MRI, my first thought is going to be multiple sclerosis, because that's going to be a common presentation. So we're gonna see issues with eye movements and that MLF. There's the blank there for you to practice on if you like. Again, I don't put this one on the test. If it's helpful, great. If it's more confusing, don't worry about it. So with the lesion on the left MLF, as shown here, you can see that lesion. I'll point it out with my red marker. Right there's where they're lesioning it. Lesion on the left MLF, as shown here, the left medial rectus muscle no longer activated during gaze. To the right, the eye cannot be moved inward on the side of the lesion, loss of medial rectus, and the opposite eye goes into an abducting nystagmus. The lateral rectus is intact and innervated by the abducent nerve. Reflex movements such as convergence are not impaired because there is no peripheral or nuclear lesion and this reaction is not mediated by the MLF. So what I like to do with these patients is figure out what they can't do, figure out what they can do, exercise that convergence in order to help with a little bit of neuro rehab and the idea of that neuroplasticity and trying to kind of realign this area here for doing a little cranial nerve neuro rehab. MLF interconnects the oculomotor nuclei and also connects them with the opposite side. So when this information highway is interrupted, we get I&O. This type of lesion most commonly occurs between abducens and ocular motor nucleus. It may be unilateral or bilateral. Again, typical causes are MS and diminished blood flow. This lesion is manifested by the loss of that conjugate eye movement or the eyes moving at the same time in the same direction.
And this brings us to the end of chapter 17, the visual pathway. This is a pretty heavy chapter. This is a lot of information. We're going to see this information again. So we've talked about it a little bit chapter by chapter, and we're going to see this again in a couple more chapters down the road. So if you feel like you still need more information, it's coming. And I will see you in later chapters. We'll talk about it in later chapters. Don't forget to check out your school webpage for your NOLTI quizzes. Okay, and email me if you need anything. See you for the next chapter.